Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels almost like engineering.
Right. It's very black and white.
Exactly. Like if you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, there it is. There's the
It's
problem.
very binary, isn't it? Broken or not broken, it's clean, it's visible, and frankly, it's comforting.
Yeah, we naturally like things to be easily categorized. But then you step into the world of gynecological health, specifically when we start talking about tissue regeneration.
Oh, yeah. That is a whole different ballgame.
Right. And suddenly that x-ray machine is completely useless. I mean, we're looking at a diagnostic and treatment landscape that is honestly incredibly murky.
Diagnostic muddy waters is kind of the perfect way to describe it. I mean, it's a field moving incredibly fast, and the data is really struggling to keep up with the clinical enthusiasm.
Well, welcome to this deep dive. Whether you are currently exploring medical options for yourself and trying to make an informed decision, or maybe you're a practitioner trying to catch up on the latest literature, or you just love digging into complex, slightly controversial science, we're so glad you're here.
We really are. And today, we are looking at the booming, fascinating, and frankly, highly debated world of energy-based devices for vaginal health.
Right. And it's a massive topic, so we are pulling from a huge stack of sources today.
Yeah, we've got comprehensive clinical trials, major meta-analyses, some pretty stark warnings straight from the FDA, and important consensus statements from the American Urogynecologic Society.
And as we were coming through all these papers, a glaring contradiction just jumped right out. It's one of those things that is simply impossible to ignore once you see it.
It really is.
You have some of these studies claiming that these energy devices have a near 100% success rate. I mean, we are talking absolute miracle territory for treating really frustrating conditions like genitourinary syndrome of menopause or stress urinary incontinence.
Yet, when you turn the page to other sources, like, say, a highly respected landmark 2021 study published in JAMA, they conclude these very same devices perform absolutely no better than a placebo.
Which is staggering. I mean, how can the smartest people in the room look at the exact same technology, running trials on the exact same human anatomy, and get totally opposite results?
It's the big question.
Well, that is our mission today. We are going to uncover exactly why the study results vary so wildly, specifically between laser treatments and radio frequency devices. So, okay, let's unpack this.
Yeah, to really grasp why the data is all over the map, we have to start at the foundational level, which is the physics of how these tools actually interact with human tissue.
Right, because they aren't all doing the same thing.
Exactly. The term energy-based devices is thrown around as this, broad umbrella term. But honestly, doing that does a massive disservice to the complexity of what's happening. It lumps together tools that perform fundamentally different biological actions.
It feels a bit like, I don't know, putting a microwave and a blowtorch in the same category just because they both heat things up.
That captures the disparity perfectly. So let's look at the three main technologies popping up in the literature. First, we have CO2 lasers.
Okay.
And these operate at a very specific wavelength of 10,600 nanometers. Now, that number matters because wavelengths dictate what the laser is attracted to.
Right.
And the primary target for a CO2 laser is the water inside your tissue.
And human tissue is mostly water, so I imagine that interaction is pretty intense, right?
Very intense. When the laser hits, it heats that intracellular water to incredibly high temperatures, between 120 and 200 degrees Celsius.
Wow.
Yeah. This instantly boils the water, which creates what the medical field calls microablative injuries.
Let's pause right there because ablatives is a heavy medical term. Break that down for someone who isn't a physicist. Like, what does that actually look like?
Right, so ablation essentially means removal or vaporization. The laser is literally vaporizing tiny microscopic columns of tissue. It's punching incredibly small holes into the vaginal wall.
Just tiny little holes.
Exactly. And the reason they do this is to trigger a severe biological healing cascade. The body detects this trauma and rushes in to repair it by creating brand new collagen.
Got it. And the clinical term for this is neocollagenesis. Neo meaning new, collagen being the structural protein.
You got it.
So you are essentially causing controlled high heat damage to trick the body into remodeling the tissue.
That's the core of it. But because it causes that deep vaporizing thermal damage, that tissue requires significant recovery time. I mean, it could take up to 20 days for the cellular structure to fully heal.
Wow. Okay. So the CO2 laser is the heavy hitter of the group. But there's a second type of laser mentioned in the sources, the erbium laser. How does that one change the math?
Well, the erbium, or YAG laser, operates at a totally different wavelength. It's at 2,940 nanometers. Now, the crucial difference here is how it interacts with water. Its water absorption rate is 15 times higher than the CO2 laser.
Wait, 15 times higher. Does that mean the erbium laser goes way deeper, or is it the other way around?
It's actually the exact opposite. Because the water in the tissue absorbs that specific wavelength so rapidly, so efficiently, the laser dumps all of its energy almost immediately upon hitting the surface.
Oh, I see.
Yeah, it penetrates incredibly shallowly, only 1 to 3 microns deep.
So it barely scratches the surface before running out of steam.
Precisely. And because of this shallow penetration, practitioners often use it in a cold ablation or non-ablative mode. It isn't vaporizing deep columns of tissue like the CO2 laser.
Right.
Instead, it's prioritizing patient comfort and surface level tightening. Because the trauma is so much less severe, the recovery time is drastically reduced. Usually just about 2 days compared to the 20 days for CO2.
Okay, so those are our two types of light-based lasers, but the third major category we found in the literature isn't a laser at all.
Correct. That brings us to radiofrequency, or RF devices, like ThermuVA or Empower RF. And these do not use light beams.
What do they use?
They use high-frequency electromagnetic waves or electrical currents. Instead of a high-heat zap that vaporizes water, RF heats the tissue to a much lower sustained temperature, usually hovering right around 40 to 45 degrees Celsius.
Which is warm like a hot tub, but definitely not boiling.
Exactly. And that lower heat allows the practitioner to push the thermal energy much deeper into the tissue without burning the surface.
Oh, wow.
Yeah, it safely bypasses the top layer to contract the existing collagen fibers deep down without causing any cell necrosis or surface damage. There's absolutely no vaporization happening with RF.
I'm trying to picture how wildly different this is for the tissue itself, and I keep coming back to, like, lawn care.
Lawn care. I like
Yeah,
it.
is it kind of like taking care of a golf course?
Yeah.
The CO2 laser is like aerating the lawn. You're driving a heavy machine over the grass, physically punching deep, destructive holes into the dirt to shock the roots into growing back thicker and stronger.
Right.
But radio frequency, that's more like installing an underground radiant heating system. You are just warming the soil from deep below to stimulate the roots without ever breaking a single blade of grass on the surface.
That is a brilliant analogy. The physical microdestructive trauma of aeration versus the gentle, deep thermal diffusion of underground heating, they achieve completely different structural changes.
But here's what I don't get. If these tools are interacting with the vaginal tissue so completely differently, like one is vaporizing holes, one is gently warming deep muscles, isn't comparing their clinical trial results basically impossible?
Yeah.
Like, how can you put them head to head on the same chart?
That hits on the exact reason the data is so conflicted. When you try to measure their success side by side, the comparison inherently skews the result depending entirely on what the researchers decide to measure.
Right.
If a study is specifically looking for surface epithelial thickening, like making the top layer of skin thicker, the CO2 laser might look like the clear winner because of that intense surface ablation.
But if they measure something else,
Right. If the study is looking for deep fascial tightening without requiring the patient to take 3 weeks off for recovery, the radiofrequency device might look far superior.
which means the success rate is often just a reflection of the test's design, not necessarily the device's overall superiority.
Exactly.
And that brings us to an even bigger problem in how these tests are designed. This part, frankly, blew my mind. Let's talk about the placebo problem.
Oh, yes. This is what the medical community calls the gold standard gap.
Right, because we looked at this massive systematic review published in Urology Times,
Yeah.
and they looked at a huge pool of available data and found that 93.5% of studies reported positive outcomes for these energy-based devices.
That's a huge number.
It is. If you are a patient reading that, it sounds like an absolute slam dunk, 93.5%. But when you look closely at how those studies were conducted, the vast majority of them lacked a sham control group.
Right.
They didn't use a placebo.
And in clinical research, especially concerning pain, sexual function, and sensitive anatomy, if you don't control for the placebo effect, your data is incredibly vulnerable to bias.
I mean, it has to be.
That is exactly why that 2021 JAMA study by Lay and colleagues caused such an absolute shockwave in the urogynecology world. They ran a double-blind, randomized clinical trial, and most importantly, they actually compared a fractional CO2 laser to a sham treatment.
But wait, how do you even do a sham laser treatment? Like, they just didn't step on the pedal to fire the laser.
Actually, they used a specially designed fake probe. It was engineered to mimic the exact sounds of the laser firing. It applied the exact same physical pressure inside the vaginal canal. And it even mimicked the mechanical sensation.
Oh, wow. So they really sold it.
Completely. The patients in the chair didn't know if they were getting the real 200-degree laser or the fake probe. And crucially, the doctors assessing their progress months later didn't know either.
So it's as controlled as it gets. What were the results?
Well, both groups. The women who received the actual tissue vaporizing laser and the women who received the completely fake probe saw a 20% improvement in their symptoms.
Wait, really? Both groups?
Both groups. The laser showed absolutely no statistical difference from the placebo when they measured the outcomes using the vulvovaginal symptom questionnaire.
And that completely aligns with the bombshell statistic we found in the Weinberger meta-analysis. They stated that 67.7% of the treatment effect for female sexual dysfunction is entirely attributable to the placebo effect.
It's wild.
Nearly 68% of the improvement is just the brain doing the work.
It is a profound testament to the power of the mind-body connection.
But wait, I have to push back on this idea of the sham being a completely inactive placebo, like, swallowing a sugar pill.
Okay, let's hear it.
We are talking about a highly vascular, incredibly nerve-dense area of the body. If this sham probe is mimicking the physical pressure, creating mechanical friction against the vaginal wall, plus you have the sounds, the clinical setting, the expectation of care, could the mere act of this sham procedure actually be physically stimulating blood flow? Or triggering a severe physiological relaxation response in the pelvic floor muscles? Like, are we absolutely sure the sham is doing literally nothing to the tissue?
That is a phenomenal observation, and it's actually a question that researchers are actively debating right now.
Oh, really?
Yeah. You're completely valid in pointing out that mechanical stimulation in the pelvic floor can dramatically increase perfusion, which is blood flow. And this dynamic is exactly why we see such a wild, confusing divergence between subjective and objective measurements in these trials.
Okay, break down the difference between subjective and objective in this context, because I think that's crucial for the listener to really understand.
Sure. So subjective measurements are usually surveys, things like the Female Sexual Function Index.
Like rating your pain on a scale of 1 to 10?
Exactly. The patient fills out a form rating their personal experience of pain, their level of desire, their natural lubrication. Those survey scores often skyrocket after treatment.
Which speaks to that massive placebo expectation or the mechanical stimulation effect you just mentioned.
Right, but objective measures are things a doctor can tangibly verify, like taking a physical biopsy of the vaginal wall and looking at the cells under a microscope, or measuring the vaginal health index.
So one is, how do I feel? And the other is, what do the cells actually look like?
Exactly. And in some of these tightly controlled trials, the subjective surveys showed massive, life-changing improvement for the patients, while the objective biopsies showed zero histological change at the cellular level when compared to the sham group.
Wow.
The tissue looked identical to how it looked before the treatment.
So the patient feels 100% better, which is wonderful, but the microscope says nothing actually changed biologically. No wonder the data is a mess.
It really is.
But let's say we strip away the placebo effect entirely. Let's imagine we are looking at two different clinics. They are treating the exact same condition using the exact same brand of CO2 laser, and they still get conflicting success rates. How is that even possible?
Well, that introduces the next major hurdle, which is the lack of standardized protocol. There's essentially no universally agreed upon instruction manual for these devices.
Wait, really? No instruction manual?
No standardized one, no. The consensus statement from the American Urogynecologic Society highlighted this as a critical crisis in the field. They noted a severe lack of standardized research definitions and highly diverse, unregulated modalities.
It's almost like handing 100 photographers the exact same high-end professional camera, but giving them absolutely no training on what shutter speed, aperture, or ISO to use, and then wondering why half the photos come out blurry and the other half belong in a museum.
That's a great way to visualize it. The machine is capable, but the operator settings change everything. Let's look at the specific protocol variations we found in the literature.
Okay.
You have some clinical trials using a power setting of 30 watts on the laser, while others crank it up to 40 watts.
And I'm guessing that matters.
Hugely. That 10-watt difference drastically changes the thermal damage zone in the tissue. Some practitioners use a fractional density 4%, others use 5%.
And then there's the dwell time, right? Like how long The laser actually sits on one specific microscopic spot.
Yes. Some studies leave the laser on a single spot for 1,000 microseconds, while others only use 800 microseconds.
It sounds like splitting hairs, but at a cellular level, that's massive.
It is. And the intervals between the sessions are completely all over the map, too. Some clinical studies make patients wait 4 weeks between treatments to allow for healing, while others wait much longer.
But the variable that seems the most frustrating, especially for a patient trying to make a medical decision, is the timeline of efficacy. Like, when are we actually deciding if the treatment, quote unquote, worked?
Oh, the timeline skews the data incredibly heavily.
Yeah.
If we look at the short-term study, say researchers surveying patients 6 to 12 months out from their procedure, the results look incredibly promising.
Right.
The neocollagenesis is fresh, the tissue is plump, and the symptoms are reduced.
But then you zoom out, you look further down the road.
When you do, the picture changes entirely. We found a study that followed patients for 1 to 3 years post-CO2 laser treatment.
Okay, what did they find?
It found that almost all the initial symptom improvements, the relief from itching, the vaginal dryness, the painful intercourse associated with the genitourinary syndrome of menopause, they all faded over time as the body's natural aging process resumed.
Wow, all of it faded.
Pretty much. The only thing that showed a slight retention of improvement was urinary incontinence.
You know, if you are the person in the chair paying thousands of dollars out of pocket for this, that is vital information. Reading one study from 6 months out makes it look like a permanent miracle cure, but reading another study from 3 years out makes it look like a temporary bandage.
And this lack of standardized maintenance protocols, not having a clear scientific consensus on exactly how many touch-ups are needed and at what specific intervals, makes comparing long-term data nearly impossible.
That makes total sense.
Yeah, a device might look like it failed in a 3-year study, not because the technology is flawed, but simply because the patient wasn't given the necessary annual maintenance session that the biological remodeling process actually requires to sustain those new collagen fibers.
Okay, so we've blamed the wildly varying physics of the technologies, we've blamed the massive placebo effect and the lack of sham controls, and we've blamed the chaotic, unstandardized power settings.
Yep, it's a long list.
But even with the perfect settings and a tightly controlled study, there is one final piece of the puzzle that explains why these study results vary so wildly. It's the human element.
The specific patients participating in these trials, everybody is different, and the baseline health of the tissue dictates the outcome.
Let's dig into who is actually sitting in the chair, because treating one patient's condition is not the same as treating another's, even if they have the exact same diagnosis. We found a direct comparative study that pitted the CO2 laser against radiofrequency, specifically for treating stress urinary incontinence, or SUI. And the results were fascinating. They showed that the CO2 laser was highly effective, but only for mild cases of incontinence.
And that makes perfect sense when we recall the mechanism we discussed earlier.
The surface-level ablation?
Exactly. The CO2 laser works through surface-level thermal stripping. It powerfully contracts the superficial mucosa, which physically pulls and tightens the urethral folding angle.
Right.
So for a mild case of leaking, that surface-level shrink-wrapping effect is enough to stabilize the urethra and stop the problem. But for severe incontinence,
the CO2 effectiveness just drops off a cliff.
Because severe incontinence often involves deeper structural failure in the pelvic floor. The surface mucosa isn't the root of the problem anymore, and that is exactly where radiofrequency shines.
Because it goes deeper.
Yes. RF penetrates much deeper, reaching into the deep pelvic fascia and the actual ligaments. Its clinical effects might take longer to appear because it's working on slow, deep tissue remodeling, but the literature suggests RF is much more durable for moderate to severe cases because it acts on the underlying muscle layer, not just the surface skin.
It's like doing home repair.
Okay, here we go.
No, seriously, think about it. If you have a slightly loose door hinge, just tightening the surface screws works perfectly. That's the CO2 laser for mild incontinence.
Right.
But if the actual wooden door frame is rotting inside the wall and structurally failing, tightening the surface screws won't hold it for long. You need to get behind the drywall and reinforce the deep studs. That's the RF device for severe incontinence.
That is exactly the dynamic at play. But beyond just the severity of the condition, we also have to look at the patient's biological baselines before they even start the trial.
What do you mean?
Well, some of these clinical trials specifically include breast cancer survivors.
Yeah.
Now, these are women who often cannot take any systemic or topical estrogen therapies due to their cancer risks.
Right.
As a result, their vaginal tissue is highly atrophic. It is incredibly thin, very fragile, and lacks natural elasticity.
And you contrast that with other trials testing the exact same machines, but they include women who were pre-treated with topical estrogen creams for weeks before the laser was even turned on.
Exactly. Or trials testing these devices on healthy premenopausal women who are simply looking to improve postpartum vaginal laxity after childbirth. Their tissue is robust, estrogen-rich, and basically ready to heal.
It creates an impossible comparison. Evaluating these devices without stratifying the data for patient severity and tissue health is just an exercise in futility.
It really is.
Here's where it gets really interesting. It means that if you test a surface-level CO2 laser on a severe deep fascia incontinence issue, it's going to fail. Not because the device is a scam, but because it was the completely wrong tool for the job. A device might, quote-unquote, fail in a clinical trial simply because it was tested on the wrong severity of the condition, or on a breast cancer survivor whose tissue was simply too atrophic and fragile to mount that aggressive neocollagenesis healing response that the laser literally demands.
Which is why the sweeping claims of 100% success or completely ineffective are both inherently flawed. Context is everything.
So when we look out over this entire murky landscape we've explored today, we set out on a mission to understand why the clinical study results for vaginal energy-based devices vary so wildly, and we found that it really boils down to four moving targets.
Right.
First, researchers are testing fundamentally different energies, the water vaporizing high-heat lasers versus the deep-heating, non-ablative radiofrequency currents.
The second, we have a massive placebo problem. The vast majority of trials fail to use sham probes, meaning a huge percentage of the reported benefits might just be psychological expectation or unintended mechanical stimulation.
Third, there is total protocol chaos. Providers are using different wattages, different dwell times, and measuring success on completely different timelines, anywhere from 6 months to 3 years.
And finally, the patient populations are vastly different, ranging from highly atrophic breast cancer survivors to health of the postpartum women across completely different severity levels of incontinence.
The overarching takeaway for anyone navigating the space is the absolute necessity of looking at medical claims with a highly critical eye.
For sure.
If you are exploring these options, it means you have to look past the glossy marketing brochures in the waiting room. You need to ask your provider if the data they are quoting is sham-controlled. Ask them about their specific power protocols and their long-term maintenance plans.
Yeah, that's crucial.
But most importantly, find a practitioner who isn't just selling one machine, but someone who truly understands how to match the specific physics of the technology to your unique anatomy and the exact severity of your symptoms.
And as we wrap up, I want to leave you with a final thought to mull over, kind of building on the most surprising thing we discussed today.
The placebo effect.
Yes. We mentioned that in some meta-analyses, up to 67.7% of the reported benefits for female sexual dysfunction are chalked up to the placebo effect.
Which is still just a mind-bending number to me.
It is. But instead of viewing that as a failure of the technology, think about what that statistic actually represents. It means the human body successfully reduced its own pain, increased its natural lubrication, and drastically improved sexual function, simply because the brain believed it was receiving a highly advanced, expensive laser treatment.
The brain literally orchestrated a biological healing response in the pelvic floor.
Precisely. So perhaps the medical community is looking at this entire field somewhat upside down.
How so?
What if the most powerful device in treating these intimate conditions isn't the CO2 laser, or the erbium laser, or the radiofrequency probe? What if the most powerful device is the largely untapped neurobiological connection between the brain and the pelvic floor?
Oh, wow, that completely flips the script.
The real frontier of urogynecology might not be inventing a more expensive, harder laser. It might be figuring out how to harness that innate neurological healing power directly. If we can map exactly how a fake sham probe triggers a 20% tangible reduction in symptoms, that's where the next true medical revolution lies. We need to fix the metaphorical X-ray machine so we can finally see the true source of the healing in those muddy waters.
What a profound way to look at it. A reminder that sometimes the most advanced, capable technology is the biology we already possess, just waiting to be activated. Thank you for taking this deep dive with us today. Keep questioning the headlines, keep looking for the nuance, and we will catch you on the next one.